If you've been around in critical care for a while, you've probably heard about CRM, Crisis Resource Management. There's an oft-quoted statistic that over 70% of avoidable deaths in healthcare involve a breakdown of the principles of CRM. Right about now, you might be thinking, yeah, I've heard it all before. So I ask you to bear with us as my husband and I share with you the very personal story of our son's birth. Our story clearly illustrates how the 7 principles of CRM failed, leading to a disastrous outcome for our son. At 7 a.m. on a fine June day in 1996, a student midwife eagerly gowns up, ready to deliver our first baby. I've been in labour since midnight. He performs a vaginal exam and declares my cervix 9 centimetres dilated. Clutching the hand of my husband, I prepare myself for the final stretch of the birth. Sadly, a more experienced midwife performs another exam and notes the cervix is only 6 centimetres dilated. The student quietly disappears, having delivered only a crushing disappointment. He was clearly unfamiliar with the environment of a woman's cervix during labour.
By 8 a.m, the fetal heart rate is persistently abnormal, a tachycardia with decelerations. One deceleration reaches a nadir of 75 beats per minute and takes a full minute to recover. Against this background, the midwife stops recording the fetal heart rate, resulting in a lack of vital information for almost an hour. At 9 a.m, the midwife alerts a doctor regarding persistent fetal tachycardia. This is a fine example of calling for help early. Unfortunately, the doctor in question never appears in the birth suite.
At 10 a.m, the midwife initiates an oxytocin infusion to increase uterine contractions, in direct contraindication to the unit's own guidelines. An independent reviewer later declares that this decision invited deterioration in the fetal condition. The midwife was understandably focused on hastening the labour, but neglected to take account of the fetal distress that had been evident for some hours. There is no evidence that a doctor was consulted. Lack of situational awareness, combined with poor communication among the healthcare team, now start to align like the holes in slices of Swiss cheese.
At 12 noon, the midwife writes a comment about the complicated fetal tachycardia but does not call a doctor. If a doctor had seen the abnormal trace at this time, the oxytocin infusion could have been stopped. If there was no immediate improvement, the labour could have been terminated at that point by caesarean section.
This intervention would have delivered Christopher before 1 p.m. As it is, the situation continues until 1:05, when the midwife records a deep, late deceleration of the fetal heart rate down to 65 and increases the IV fluids. At 1:15, a junior doctor finally appears on scene.
I tend to trust medical professionals and am very reluctant to question them. But as the hours passed and I noted their furtive, worried expressions and agitated comings and goings, I became increasingly alarmed. I didn't realise it at the time, but it's clear to me now that I was witnessing hesitation, confusion and inertia in the very people to whom I had entrusted the life and well-being of my unborn son.
From 1 p.m. onwards, the abnormalities on the heart trace become more marked, and no sooner has a baseline been recovered than there is a further prolonged and profound deceleration. During this time, the doctor is engaged in taking a fetal scalp blood sample, the result of which is recorded as pH 7.04.
This decision reflects a complete lack of situational awareness. In the words of our independent reviewer, if there was an indication for a fetal scalp blood sample, it was at a much earlier stage, when information about the baby's condition would have been helpful in management. At 1:34 p.m, the trace deteriorates into terminal bradycardia, reflecting a profound hypoxic ischemic event. 1 minute later, a senior doctor happens by the birth suite, assesses the situation, and quietly yet firmly states, Caesar. The team, seemingly lost until this moment of decisive leadership, is galvanised into action. Christopher is delivered 16 minutes later with an APGAR score of 0. Had a similar decision been taken on the first doctor's arrival, as it should have been, Christopher would have been born at 1:26 p.m. It is overwhelmingly probable that Christopher's severe brain injury occurred during the 17 minutes of terminal bradycardia, plus the subsequent resuscitation immediately following his birth.
We had no medical background when Christopher was born all those years ago. It's only now, as an emergency nurse, that I can look back and see the sequence of CRM failures that led to Christopher's permanent disability. This story isn't about the failure of individuals' technical skills. It's about the human and systemic factors that allowed our baby's persistent in utero distress to develop into a full-blown medical emergency. As a nurse, I constantly challenge myself to improve my technical skills for future emergencies, but it's at least as important for medical staff to hone their skills of communication, situational awareness, leadership, anticipation, and planning.
Christopher will live out his life in a wheelchair, unable to use his arms and body in any meaningful way. His access to the world is through the monotonous tapping of a switch. I think it's only fair to let him have the last word.
Disobedient and my eyes.